Imagine the body's main pipeline suddenly tearing, creating a new, chaotic channel for blood flow, threatening vital organs in an instant. This isn't just a medical drama scenario.
No, it's the terrifying reality of acute disorders affecting the descending thoracic aorta. And these conditions, they demand rapid diagnosis, precise management, often really against the clock.
Welcome to the Deep Dive, your shortcut to being well-informed without getting buried in information overload. Today, we're diving deep into the critical world of descending thoracic aorta disorders.
It's a complex area, definitely.
Our source material is a real cornerstone document in vascular surgery, the European Society for Vascular Surgery, or ESVS, clinical practice guidelines for managing these specific conditions. Think of these guidelines as a synthesis of the best available evidence out there.
Exactly. They're designed to support clinical decision-making in these challenging cases. They evaluate the evidence, really to help physicians navigate the complexities and select the most appropriate management strategies.
So not rigid rules, but a vital resource.
Precisely. They inform your ultimate decisions for each unique patient you see.
Okay. Our mission then is to guide you through this dense but crucial material, highlighting the most important insights, the key recommendations. We're covering a broad spectrum here.
We really are, from degenerative and genetic issues right through to traumatic injuries. And the focus is squarely on the descending thoracic aorta that's from just after the left subclavian artery origin down to the diaphragm.
And even extending into the thoracoabdominal segment sometimes.
Yes, that too. We'll explore how these different conditions present, the essential diagnostic imaging tools you'll be relying on, and critically, the evidence, the data underpinning those treatment choices.
Including the guidelines' use of evidence levels and recommendation classes, which is important.
Very important. We'll be mentioning those throughout.
Okay, let's set the scene a bit. The descending thoracic aorta. We're talking about the major artery running down your chest after the aortic arch, carrying blood from the heart to, well, everywhere else.
And it has those critical side branches, doesn't it? Supplying blood to the spinal cord via intercostal and spinal arteries, the bronchial arteries too.
Right. And its normal diameter, that varies a bit, doesn't it? Based on sex, age, body size.
It does, but significant enlargement. That's the key sign of an aneurysm, of trouble brewing.
And the wall itself, 3 layers.
That's right. The inner intima, the muscular media that gives it its strength, and the outer adventitia. Damage to these layers, often starting right at the intima, is really the root cause of so many of these problems.
And risk factors like smoking, hypertension, high cholesterol, diabetes. They all play a part in weakening that wall.
They absolutely do. They compromise the wall, particularly the intima, making it susceptible to disease. It's a vulnerable vessel.
And the guidelines suggest the true incidence, the number of people affected, is probably higher than we officially think.
Yes, that's a point they make. Because DTA-related death can sometimes be mistakenly attributed to other cardiac issues, like a heart attack.
It's often a combination of factors then. Maybe the genetic predisposition meeting environmental risks.
Very often, yes. The pathophysiology is frequently multifactorial. It's not just aneurysms either. This segment of the aorta is affected by a wide range of disorders.
Like acute aortic syndromes.
Exactly. That group includes aortic dissection, penetrating aortic ulcer, or PAU, and intramural hematoma, IMH.
And the most common acute emergency we see in this area?
That would be acute type B aortic dissection, or ATBAD. The guidelines report an incidence that actually seems to be increasing. We're looking at somewhere between 2.9 or 4.0 cases per 100,000 people per year.
That's significant. And the scope of the guidelines goes even wider than dissections and aneurysms.
Oh, absolutely. They cover descending thoracic aortic aneurysms, DTAA, and thoracoabdominal aortic aneurysms, TAAA. Also, traumatic aortic injuries, inflammatory conditions like Takayasu and giant cell arteritis, Beset disease too.
Plus congenital issues like coarctation and those really crucial genetic syndromes.
Yes, Marfan, Loeys-Dietz, Ehlers-Danlos syndrome, Turner syndrome, familial links. It's a broad church of pathology.
Okay, that gives us a really good landscape of what we're dealing with. So when someone presents with symptoms suggestive of one of these conditions, maybe severe pain diagnosis is paramount, and it's often incredibly time-sensitive.
Absolutely. History and physical exam are your starting point, of course. You're looking for those pain patterns, murmurs, checking pulses, blood pressure differences between arms.
But the definitive diagnosis, that really comes down to imaging, doesn't it?
It does. Image-based diagnosis is key. And the guidelines are very clear on the primary tool here.
Which is?
Computed Tomographic Angiography, CTA. It's really positioned as the gold standard. It's fast, it's widely available these days, and it offers incredibly high sensitivity and specificity. We're talking up to 100% sensitivity and maybe 98, 99% specificity in some studies.
Wow. What makes CTA so dominant in this setting?
Well, its speed is a huge factor in acute situations, and the detailed visualization you get, a comprehensive 3D view of the aorta, its branches, any tears, ulcers, hematomas. That's all there.
Are there downsides we need to consider?
Of course, there's the radiation exposure, which is always a consideration, especially for repeat scans, and the need for intravenous contrast, which can be nephrotoxic. But for patients where you have a clinical suspicion, maybe an abnormal chest X-ray, the recommendation is strong. Get the CTA to confirm or rule out the diagnosis.
And that's a Class 1 level fee recommendation.
That's correct. Class 1, level C. Strong agreement based on, well, clinical necessity and expert consensus, even if large trials aren't the basis.
Class 1 level C.
Got it. What about other imaging tools? Is magnetic resonance imaging, MRI, useful here?
MRI is an excellent tool, certainly. It has the major advantage of using no ionizing radiation, which makes it particularly good for follow-up, especially in younger patients needing multiple scans over time.
And it gives good soft tissue detail. Very good. That's helpful for looking at the aortic wall itself, maybe differentiating intramural hematoma or assessing inflammation in aortitis. It can be an alternative if contrast for CTA is a major concern, though gadolinium contrast is often still used with MRI. Its comparability to CTA and TOE is noted in the guidelines.
Okay, and Transesophageal Echocardiography, or TOE, where does that fit in?
TOE has its roles. It can visualize the descending thoracic aorta, well, usually from the left subclavian down towards the celiac artery. It's useful for differentiating components of acute aortic syndromes and can provide functional information preoperatively or intraoperatively.
High sensitivity and specificity reported for TOE, too.
Yes, quite high, around 98% sensitivity and 95% specificity are quoted. But it is semi-invasive, requires sedation, patient cooperation, and often the CTA has already provided the necessary anatomical detail more comprehensively and less invasively. So it's often seen as a second-line diagnostic tool after CTA or for specific intra-op use.
Any other imaging for more niche situations?
Well, yes, positron emission tomography, PET, usually combined with CT, PT-CT, is really vital for diagnosing and particularly for monitoring the activity of inflammatory aortitis. It looks at metabolic activity in the vessel wall.
Limited availability, though.
Can be, yes,
Yeah.
but very valuable for those specific inflammatory conditions. And then there's intravascular ultrasonography, IVUS.
Inside the vessel itself.
Exactly. It's invasive, you need arterial access, and it's operator dependent. But it can be incredibly helpful intraoperatively, or when CTA or angiography images are maybe inconclusive. It gives you dynamic, real-time evaluation right there in the lumen.
Okay, so a whole suite of imaging tools, but CTA is really the workhorse for that initial rapid diagnosis in suspected acute cases. Let's focus now on that most common emergency you mentioned, acute type B aortic dissection, ATBAD. What's actually happening inside the aorta there?
It fundamentally starts with a tear, an intimal tear in that inner lining of the aorta. This tear allows blood under pressure to surge into the aortic wall itself, specifically into the media layer. It splits the layers of the media apart.
Creating a second channel.
Precisely, creating a false lumen alongside the original true lumen. And in type B dissections, by definition, this process starts distal to the origin of the left subclavian artery. That's the most common location for the primary entry tear.
And you mentioned classifications earlier, Stanford and DeBakey. How do they relate here?
Right. The Stanford classification is probably used more commonly now because it's simpler and more clinically relevant for immediate management decisions. Stanford type A means the ascending aorta is involved, regardless of where the tear started. Stanford type B means the ascending aorta is not involved. The dissection is confined to the descending aorta.
So type B is our focus today.
Yes, Stanford type B is broadly comparable to the DeBakey type 3 classification, which also describes dissections originating in the descending aorta. And remember the timing. Acute is generally defined as symptoms presenting within the first 14 days.
Okay. Who is most at risk for developing an acute type B dissection?
Well, by far the biggest single risk factor is systemic hypertension. It's present in something like 80% of patients. Chronic high blood pressure just puts immense stress on that aortic wall over time.
Other factors.
Age is a factor, atherosclerosis certainly contributes, but it's really crucial, especially when you see younger patients, to think about underlying connective tissue disorders.
Like Marfan syndrome.
Exactly. Marfan, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome. These conditions cause inherent weakness in the aortic wall. The guidelines highlight that in patients under 40 who present with an aortic dissection, about half might have one of these underlying genetic conditions.
Which has implications beyond treating the dissection itself.
Absolutely. It means genetic counseling is really important, a Class 1, Level C recommendation, in fact, not just for the patient, but for screening family members, too. Other risk factors include things like bicuspid aortic valve, cocaine use, pregnancy even, and interestingly, ATBAD can occur even with normal aortic diameters, though the risk definitely increases with aortic dilation. A mean diameter over 41 millimeter has been reported as conferring increased risk.
Now, symptoms. We often think of that classic tearing pain.
And that is the hallmark. Acute, excruciating chest pain, often radiating to the back between the shoulder blades. That's reported in about 80% of cases. But the presentation can be much more varied and sometimes atypical.
Such as?
Patients might present with abdominal pain, syncope or fainting, maybe pulse deficits in their limbs, or signs that blood flow is being cut off to vital organs, what we call malperfusion. This could affect the gut, the kidneys, the legs, even the spinal cord, leading to paraplegia.
And recognizing these atypical presentations is critical because they might indicate a worse prognosis.
Yes. Data from the International Registry of Acute Aortic Dissection, that's IRE, has shown that certain features like hypotension, absence of pain, or any evidence of branch vessel involvement and malperfusion are predictors of higher mortality. It really underscores the need for a low threshold for imaging if you have any suspicion, even if the presentation isn't perfectly classic.
This naturally leads to that crucial distinction you mentioned earlier, complicated versus uncomplicated acute type B dissection.
Yes, this is fundamental to initial management. Complicated ATBD means there are signs of severe life-threatening issues. This includes rupture or impending rupture, any evidence of malperfusion causing organ or limb ischemia, refractory or uncontrollable pain despite medication, refractory hypertension, or signs of rapid aortic expansion on imaging.
And the outcomes for complicated cases are much worse without intervention.
Much worse. These patients face a very high mortality risk if managed with medical therapy alone. Some reports suggest in-hospital survival might only be around 50% in that scenario. Urgent intervention is usually required.
Okay, and uncomplicated ATBD.
Uncomplicated means none of those severe features are present initially. So no signs of rupture, no malperfusion, pain, and blood pressure are controllable with medication. About half of acute type B dissections fall into this category at presentation.
Still serious, though.
Oh, absolutely still serious. The immediate risk is lower than complicated cases, but in-hospital mortality for uncomplicated ATBAD managed medically can still be up to 10%, and there's the risk of developing complications later.
So the presence or absence of these complications really dictates the initial management strategy, doesn't it?
It absolutely does. It's the first major decision point. For uncomplicated acute type B dissection, the cornerstone, the initial approach, is aggressive medical management. This is a Class 1 Level C recommendation.
And what does that involve? What are the goals?
The primary goal is to reduce the stress on the damaged aortic wall. You want to decrease the hemodynamic forces that could propagate the dissection or lead to rupture. This means aggressively lowering the blood pressure.
Target numbers.
Aiming for a systolic pressure, typically between 100 and 120 millimeters of mercury, as long as vital organ perfusion is maintained. And also controlling the heart rate, reducing the shear stress. The goal there is usually less than 60 beats per minute if hemodynamically tolerated.
What medications are used?
Intravenous beta blockers are usually the first-line agents because they reduce both heart rate and blood pressure. Labetalol or esmolol are common choices initially. If beta blockers aren't enough or are contraindicated, calcium channel antagonists like nicardipine or diltiazem can be used. Sometimes vasodilators like sodium nitroprusside are needed for fine-tuning blood pressure, but usually in combination with a beta blocker to avoid reflex tachycardia. And of course, adequate pain relief with opiates is crucial, as pain itself can drive up blood pressure and heart rate.
And does this medical management improve long-term outcomes too?
Yes, the guidelines mention that long-term survival seems improved with the use of beta blockers or calcium channel blockers. There's also some suggestion that angiotensin receptor blockers, ARBs, might be particularly beneficial in patients with Marfan syndrome, potentially slowing aortic root dilation, although the focus here is the descending aorta.
Okay, so medical therapy first for uncomplicated, but what about the complicated cases? The ones with rupture or malperfusion?
Right. For complicated acute type B dissection, the approach needs to be much more invasive. And here, thoracic endovascular aortic repair, or TVAR, has really become the first-line therapeutic option. The guidelines give this a Class 1, Level C recommendation.
TVAR. So using a stent graft, why is that preferred now?
The goal of TVAR in this setting is to cover the primary intimal tear, the entry point of the dissection. By placing a stent graft across this tear, you essentially seal it off from aortic blood flow. This redirects flow primarily down the true lumen.
And what happens to the false lumen?
Well, the idea is that sealing the entry tear reduces the pressure within the false lumen. This encourages the false lumen to thrombose, or clot off, and hopefully, over time, leads to aortic remodeling and stabilization. It can also immediately relieve pressure causing malperfusion if the false lumen was compressing the true lumen or branch vessel origins.
And the evidence supports TVAR over traditional open repair for these complicated acute cases.
Yes. While large randomized controlled trials are lacking, which is common in acute surgical emergencies, the available evidence, mostly from non-randomized studies, registries like IRAD and meta-analyses, consistently shows that TVAR has a significant early mortality advantage compared to open surgical repair for complicated acute type B dissection.
What sort of outcomes are we seeing with TVAR in this setting?
Technical success rates are generally very high, typically reported as over 95%. Hospital mortality rates vary in different series, but are often quoted in the range of about 2.6% up to maybe 9.8%. Neurological complications like stroke or spinal cord ischemia are a concern and range from approximately 0.6% to 3.1%. These outcomes are generally much better than historical outcomes for open surgery in the same acute, complicated setting.
Given the better outcomes in complicated cases, has PVAR been considered for uncomplicated cases too? Perhaps to prevent future problems?
Yes, that's a really important area of ongoing discussion and research. The rationale is that even if a patient presents with an uncomplicated dissection, they remain at risk for late complications, particularly aneurysmal degeneration of the weakened aorta, which can happen years down the line.
So the idea is preemptive TVAR.
Sort of. The thinking is that intervening early with TVAR to seal the tear and promote false lumen thrombosis might prevent or reduce the likelihood of these late adverse events. Some registry data, again from IARD, suggested a possible 5-year mortality benefit with early TVAR compared to medical therapy alone in certain uncomplicated patients.
Was there a randomized trial looking at this?
Yes, the ADS-ORB trial. It randomized patients with uncomplicated acute type BD dissection to either optimal medical therapy alone or optimal medical therapy plus TVAR. At 1 year, the trial showed significantly higher rates of favorable aortic remodeling, meaning false lumen thrombosis in the TVAR group. However, the trial wasn't powered to detect a difference in mortality or major complications at that early time point.
Interesting. So where do the guidelines land on using TVAR for uncomplicated ATBA?
It's positioned as something to consider selectively. The recommendation is that early TVAR may be considered in selected patients with uncomplicated acute type B dissection who are deemed to be at high risk for late aortic complications, with the aim of preventing those complications. This carries a Class 2B, Level B recommendation.
Class 2B, Level B. So usefulness is less well established, based on maybe a single trial or non-randomized studies, and the decision requires careful patient selection.
Exactly. It reflects that the evidence isn't definitive yet, and it's not a routine recommendation for all uncomplicated patients. Factors like aortic diameter at presentation, location of the tear, presence of partial false lumen thrombosis, and patient factors need careful consideration. These decisions are often best made in high-volume centers with significant experience in managing aortic dissections. A persistent patent false lumen after the acute phase is known to be a risk factor for chronic dilatation. For malperfusion specifically, fenestration is also an option, creating a hole between lumens that gets a Class 2A, Level C recommendation.
Okay, so TVAR is front and center for complicated and considered for selected uncomplicated cases. Given this shift, what's the current role of traditional open repair in the acute setting?
For acute, complicated type B dissection, the role of open repair has significantly decreased. As we touched on, its associated mortality rates are historically very high, often cited between 25% and 50% in the acute setting. Morbidity is also substantial, with major complication rates up to 80%.
Including neurological deficit?
Yes, particularly spinal cord ischemia or paraplegia. Rates reported with open repair in the acute setting range from about 2.3% to 6.6%, which is a devastating complication. Outcomes are heavily influenced by the patient's preoperative condition and age, especially if they're over 70. So open surgery is generally reserved for acute situations where TEVAR simply isn't anatomically feasible, or perhaps if there's extensive connective tissue disease making endovascular repair difficult.
You mentioned spinal cord ischemia, SCI. It's clearly a feared complication in both open repair and TEVAR, though maybe less frequent with TEVAR. How do the guidelines address preventing this critical issue? Let's start with open repair.
Right. SCI prevention is a major focus, especially during extensive open thoracoabdominal repairs. The risk is higher with open surgery due to the need for aortic clamping and interruption of blood flow to crucial intercostal and spinal arteries, like the artery of Adam-Kavitz. Historical techniques like the Crawford inlay method tried to preserve some intercostals, but revascularization can be challenging.
So what are the key preventative strategies used now?
A cornerstone strategy, supported by good evidence, is the use of cerebrospinal fluid, or CSF drainage.
How does that help?
By draining CSF, you lower the pressure within the spinal canal. This increases the pressure gradient driving blood flow to the spinal cord, effectively improving its perfusion, especially during periods of aortic clamping or potential hypotension.
And the evidence for CSF drainage is solid.
Yes. The guidelines cite randomized controlled trials and meta-analyses showing that CSF drainage can reduce the risk of paraplegia or paraparesis by as much as 75%. The odds ratio is around 0.48. Based on this, CSF drainage gets a strong recommendation.
What class and level?
It's a Class 1, Level C recommendation for appropriate open repair cases. The goal is typically to maintain CSF pressure below 10 millimeters of mercury during the operation, and often for 48 to 72 hours postoperatively.
Are there risks with CSF drainage?
Yes. Potential complications like headache, catheter site issues, or rarely intracranial bleeding can occur, but the incidence is generally low, less than 5% in experienced hands, and the benefits in high-risk open repairs are thought to outweigh these risks.
Other adjuncts for SCI prevention in open surgery.
Other strategies include using distal aortic perfusion techniques like left heart bypass or extracorporeal circulation to maintain flow below the clamp, inducing moderate systemic hypothermia, maybe down to around 32 degrees Celsius, and maintaining a higher mean arterial pressure, often 80 to 100 millimeters of mercury, post-operatively to support spinal cord perfusion. Monitoring techniques like motor-evoked potentials, MEPs, or somatosensory-evoked potentials, SACPs, might also be used intraoperatively. Pharmacological agents like free radical scavengers or steroids have been investigated, but the guidelines note a lack of high-quality evidence supporting their routine use.
So CSF drainage and MAP control get stronger recommendations.
Yes. Class 2A, Level C for maintaining MAP and using CSF drainage. Left heart bypass, specifically for descending thoracic aneurysm repair, gets a Class 3C recommendation, meaning not recommended as routine.
Okay, that covers open repair. What about preventing SCI during TEVAR? You said the incidence is lower, but still a concern?
Correct. Overall SCI incidence with TEVAR is lower than open repair, generally cited between 2.5% and 8%, but it definitely still happens and can be devastating.
What increases the risk during TEVAR?
Several factors are associated with higher SCI risk during TEVAR. These include having had a prior abdominal aortic aneurysm repair, experiencing prolonged hypotension during or after the procedure, having severe diffuse atherosclerosis, occlusion or coverage of the left subclavian artery origin without revascularization, occlusion of the hypogastric arteries, and perhaps most importantly, the sheer length of aortic coverage with the stent graft. The more extensive the coverage, the more intercostal arteries are potentially sacrificed.
So are preventative measures like CSF drainage used in high-risk TEVAR cases too?
Yes, the guidelines recommend considering CSF drainage in patients undergoing TEVAR who are deemed to be at high risk for SCI. This specifically includes those needing extensive aortic coverage or those who have had a previous AAA repair. This is a Class 2A, Level C recommendation.
Class 2A, Level C suggesting it's reasonable for those higher-risk individuals.
Exactly. It's not routinely done for all TEVARs, but for patients with multiple risk factors, particularly extensive coverage, the potential benefit might warrant its consideration.
You mentioned covering the left subclavian artery, the LSA, as a risk factor.
Yeah.
How is that managed? Does it always need to be revascularized if covered?
Covering the LSA origin with the stent graft can indeed increase the risk of both stroke, particularly posterior circulation stroke, and spinal cord ischemia. The recommendation is that in the elective setting, if TEVAR requires coverage of the LSA, then revascularization of the LSA, usually via a carotid subclavian bypass or transposition, should be considered.
And that's a strong recommendation.
Yes, that's a Class 1, Level C recommendation for elective cases based on the patient's specific anatomy, whether the vertebral artery is dominant, and if the left internal mammary artery has been used for a coronary bypass graft previously. In the acute setting, the decision is more complex and depends on the urgency and anatomy.
Okay, so aggressive SCI prevention strategies are vital, tailored to the type of repair and the patient's risk factors. Let's shift gears now and talk about chronic conditions, specifically chronic type B aortic dissection, CTBAD, and descending or thoracoabdominal aortic aneurysms, DTAA. First, how is chronic dissection defined again?
Right. Historically, anything beyond 14 days was considered chronic, but there's increasing recognition of a subacute phase, say from 2 weeks up to maybe 3 months, where the aorta is still remodeling. Chronic is typically used for dissections presenting or persisting beyond 3 months from the initial acute event. This category also includes patients who have a residual type B dissection remaining after undergoing repair for an acute type A dissection.
What's the natural history like in this chronic phase? Does the aorta stabilize or is there still a risk?
There's definitely still a risk. While some false lumens may thrombose and the aorta might stabilize, complications, primarily late enlargement of the false lumen leading to aneurysm formation and potential rupture, occur in a significant proportion of patients. Estimates range from 20% up to 50% over time.
What predicts that late enlargement?
Several factors are associated with late degeneration. Persistent hypertension is a major one, ongoing stress on the weakened wall. Having a larger aortic diameter, say 40 millimeters or more, during the initial acute phase is also a predictor. COPD is sometimes mentioned. But critically, a persistently patent or open false lumen, especially if it's large, maybe taking up more than 70% of the total aortic area, is a strong risk factor for late expansion. The rate of expansion can be quite variable, maybe 1 to 7 millimeters per year.
So mortality remains a concern long-term.
Yes, late mortality after surviving an acute type B dissection is unfortunately high, reported around 25% at 3 years post-discharge in some series. However, it's important to note that many of these late deaths are actually due to other cardiovascular comorbidities, heart disease, stroke, rather than direct aortic rupture in the chronic phase.
Which highlights the importance of
Aggressive, comprehensive management of all cardiovascular risk factors. Blood pressure control is paramount. Lipid management, smoking cessation, everything.
So for managing stable chronic dissection, medical therapy and surveillance remain the foundation.
Absolutely. Aggressive medical therapy, particularly with beta blockers, which have shown improved survival and freedom from aortic events in the chronic phase, and close imaging surveillance are the cornerstones of management for asymptomatic, stable chronic type B dissection.
When does intervention become necessary for chronic dissection? What are the triggers?
The primary goal of intervention in the chronic phase is to prevent that late aneurysmal degeneration and rupture. Of course, if late malperfusion develops, that also mandates repair. That's a Class 2A, Level C recommendation. But in asymptomatic patients, the main indicator becomes the size of the aorta, the diameter.
Is there a specific size threshold?
Yes, similar to degenerative aneurysms, diameter is key. The risk of rupture increases significantly once the descending thoracic aorta exceeds about 55 to 60 millimeters. The guidelines suggest specific thresholds. For diameters between 56 and 59 millimeters, repair may be considered in patients who are otherwise at reasonable surgical risk. That's a Class 2B, Level C recommendation.
And above that?
For diameters greater than 60 millimeters, repair should be considered. That carries a Class 2A, Level C recommendation. Similarly, if the dissection extends into a thoracoabdominal aortic aneurysm segment that is over 60 millimeters, repair should also be considered, Class 2A, Level C.
Okay. What are the repair options for these chronic dissections and also for primary degenerative descending thoracic aortic aneurysms, DTAA, or thoracoabdominal aortic aneurysms, TAAA? Let's start with chronic dissection repair.
For chronic dissection, traditionally, open surgical repair was considered the standard, especially in patients deemed to be at low surgical risk because long-term results were thought to be durable. However, defining low surgical risk for such a complex operation is challenging, and outcomes, particularly mortality and morbidity, including SCI, can be high outside of specialized high-volume centers. Adjuncts like CSF drainage and MAP control are still important to mitigate SCI risk in these chronic open repairs.
And TEVAR for chronic dissection.
TEVAR has been increasingly used for chronic dissection since around 1999. The goal remains similar to the acute setting: seal the proximal entry tear, redirect flow, and promote false lumen thrombosis and ideally aortic remodeling. The procedure is generally associated with lower perioperative mortality and morbidity compared to acute TEVAR or open repair for chronic dissection.
What do the midterm results show?
Midterm results for TEVAR and chronic dissection generally show low mortality, often less than 5%, and acceptable rates of neurological complications. However, delayed complications can occur, such as the development of new aneurysms distally or persistent false lumen perfusion from distal tears, which can lead to ongoing expansion.
You mentioned the INSTEAD trial earlier in the context of uncomplicated acute dissection. Did it have implications for chronic cases?
Yes, the longer-term follow-up of the INSTEAD trial, which randomized stable type B dissection patients, mostly subacute or chronic, to TEVAR plus medical therapy versus medical therapy alone, showed that at 5 years, the TEVAR group had improved aorta-specific survival and delayed disease progression. This suggests that preemptive TEVAR might be beneficial in selected stable chronic or subacute patients to improve long-term aortic outcomes. This contributes to the Class 2A, Level B recommendation for considering TEVAR in the subacute phase for suitable patients. However, the data on preventing late aortic-related deaths specifically might still be considered less robust than some long-term open repair series from expert centers.
Okay. Now turning to primary DTAA and TAA. First, definitions.
Sure. A DTAA, descending thoracic aortic aneurysm, is generally defined as a localized dilation of the aorta, usually more than 50% increase compared to adjacent normal segments, located between the origin of the left subclavian artery and the diaphragm. A TAA, thoracoabdominal aortic aneurysm, involves dilation of the descending thoracic aorta that extends down into the abdominal aorta, involving the visceral artery origins.
And there's a classification for TAA.
Yes, the Crawford classification is commonly used. It describes the extent. Type I involves most of the descending thoracic and upper abdominal aorta. Type 2 is the most extensive, from the subclavian down to the aortic bifurcation. Type 3 involves the lower descending thoracic and abdominal aorta. Type 5 is mostly abdominal, but includes the visceral segment. And Type V is a variation involving the lower thoracic aorta down to the infrarenal aorta. Visually, it helps plan the complexity of repair.
When is repair indicated for these aneurysms? Similar thresholds to chronic dissection.
Generally, yes. The primary indication for asymptomatic DTAA or TAAA repair is size to prevent rupture. A diameter threshold of greater than 60 millimeters is often used as an indication where repair should be considered, often a Class 2A Level C recommendation. Repair may be considered for diameters between 56 to 59 millimeter, often Class 2B Level C. Other indications include rapid expansion, typically defined as more than 10 millimeters per year, or the development of symptoms like pain or compression of adjacent structures.
What are the repair options for TAAA, given their complexity involving visceral arteries?
Open surgical repair remains a standard treatment, particularly for younger, fitter patients, but it's a major undertaking. It involves a large incision, extensive aortic replacement, and reimplantation of visceral and renal arteries. The risks are significant. Myocardial infarction, respiratory failure, renal failure requiring dialysis, stroke, spinal cord ischemia, paraplegia, and death.
So patient selection and center expertise are critical.
Absolutely. Thorough preoperative assessment of cardiac, pulmonary, and renal function is essential. Class 1, Level C recommendation. And there's a well-established volume outcome relationship. Results are generally better in high-volume centers performed by experienced surgeons. Adjuncts we discussed for SCI prevention, distal aortic perfusion, CSF drainage, MAP control, careful intercostal management are routinely used.
What about endovascular approaches for TAA?
Endovascular repair for TAAA is a rapidly evolving field. There are two main approaches. One is a hybrid approach, which combines open surgery, usually extra anatomic bypasses to the visceral arteries, with endovascular stent grafting of the aneurysmal aorta. This is often reserved for higher-risk patients or emergency situations with unfavorable anatomy for a fully endovascular approach.
And the other approach?
The other is total endovascular repair. This uses complex, custom-made, or off-the-shelf branched or fenestrated endografts. These grafts have openings or branches designed to align with the visceral arteries, allowing blood flow to be maintained while excluding the aneurysm sac.
How are the outcomes with these total endovascular TAA repairs?
Early and midterm results are promising, suggesting lower invasiveness compared to open surgery. However, these are still complex procedures with significant potential morbidity and mortality, especially since they're often applied to patients deemed unfit for open repair. Complications like endoleaks, branch vessel occlusion, and device issues can occur. Like open TAAA repair, outcomes tend to be better in high-volume, specialized centers with expertise in these advanced techniques. For DTAA specifically, TEVAR thresholds are similar to chronic dissection. 56, 59 millimeter may be considered Class 2B level B. 60 millimeter should be considered Class 2A level B.
It really sounds like the decision between open and endovascular repair, whether for chronic dissection or aneurysms, is highly individualized. You're weighing patient factors, the specific anatomy, the extent of the disease against the complexities of the procedure, and the available local expertise.
Absolutely. It's a constant balancing act. The guidelines provide the evidence base, but the application requires careful judgment, recognizing the limitations of the evidence in some areas, especially comparing rapidly evolving endovascular tech with established open techniques.
Let's quickly touch on a few other specific conditions covered in the guidelines. You mentioned genetic syndromes earlier, like Marfan or Ehlers-Danlos. They seem particularly important.
Crucially important, yes, because they cause inherent structural weakness in the aortic wall, often leading to dissection or aneurysm formation at a much younger age, and sometimes at smaller aortic diameters compared to degenerative disease.
Key differences between them.
Well, Marfan syndrome, caused by mutations in the FBN1 gene, classically affects the aortic root most severely. But the descending thoracic aorta is definitely involved too. Loeys-Dietz syndrome, often involving PGFBR mutations, is generally considered even more aggressive, with widespread aneurysms and a high propensity for dissection, often occurring at very small diameters. Intervention thresholds are typically much lower, guidelines might suggest, considering repair for a DTAA diameter over 50 millimeters in LDS, maybe even lower thresholds in some contexts, compared to the 60 millimeter threshold for sporadic aneurysms. Ehlers-Danlos syndrome, particularly the vascular type IV, carries a high risk of spontaneous arterial rupture anywhere, including the aorta. Turner syndrome also has associated cardiac defects and an increased risk of aortic dissection requiring screening. And familial forms of thoracic aortic aneurysm exist, often autosomal dominant, presenting younger and growing faster than sporadic cases.
So the key takeaway for these genetic conditions.
Recognize them, or at least have a high index of suspicion, especially in younger patients or those with suggestive physical features or family history. Genetic counseling, as we said, is a Class 1, Level C recommendation. Screening first-degree relatives of patients with familial DTAA is also recommended, Class 2B, Level C. And importantly, intervention thresholds are often lower, demanding a more aggressive surveillance and treatment strategy. Endovascular repair might be considered in redo situations or emergencies in connective tissue disorders, but open repair is often preferred electively due to concerns about stent graft fixation and durability in weak tissue. TEVAR gets a Class 2B, Level C for consideration in these specific scenarios.
What about inflammatory conditions like Takayasu arteritis or giant cell arteritis?
These are systemic vasculitides that can affect the aorta and its major branches, causing inflammation, thickening, stenosis, or aneurysmal dilation. The first line of management is typically medical therapy to control the inflammation.
Corticosteroids.
Yes, corticosteroids are first line, Class 1, Level C, often followed by tapering strategies and sometimes the addition of other immunosuppressants or biologic agents. Tapering gets a Class 2A, Level C. Surgical or endovascular repair might still be needed if significant aneurysms develop or if end-organ ischemia occurs due to stenosis. Class 2A, Level C indication, similar principles to non-inflammatory disease. However, intervention needs careful planning around disease activity, as operating during active inflammation can increase risks, and tissue fragility, particularly in conditions like Behçet disease, can be a concern. Perioperative immunosuppression is often recommended, Class 2A, Level C.
Okay. And coarctation of the aorta presenting in adults.
Right. This is a congenital narrowing of the aorta, typically located near the ligamentum arteriosum, just distal to the left subclavian artery origin. In adults, it often presents with hypertension, particularly upper extremity hypertension compared to lower extremities, maybe differential pulses, or sometimes claudication.
How is it diagnosed and treated?
Diagnosis is usually confirmed with imaging. CTA or MRA are recommended. Class 2A, Level C for MRA. Repair is generally indicated for symptoms: a significant pressure gradient across the coarctation, often 20 milli-Hg, or associated systemic hypertension. Class 1C for gradient symptoms, Class 2AC for hypertension 430/90. Both open surgical repair and endovascular intervention are options.
How do they compare?
Open repair generally has low mortality, but potential complications like recoarctation or late aneurysm formation at the repair site. Endovascular repair using balloon angioplasty, often with stent placement, has very low perioperative mortality, but historically had higher rates of recoarctation or aneurysm formation compared to surgery, although stent placement seems to reduce these late complications. Endovascular repair is considered a reasonable alternative in patients with suitable anatomy, Class 2A, Level C. Given the complexities and long-term follow-up needed, centralization of treatment to expert centers is suggested, Class 2B, Level C.
Briefly, the guidelines also mention rare things like aortic tumors.
Very rare, yes. Usually malignant sarcomas. Diagnosis is challenging. They can mimic other conditions. Imaging like PT-CT can be useful, but biopsy confirms it. Unfortunately, outcomes are generally poor, even with aggressive surgical resection. Endovascular repair is explicitly not recommended, as stents won't address the malignancy, except perhaps in palliative situations for embolic events.
And floating thrombus in the DTAA.
Another uncommon but important finding. It's a mobile thrombus attached to the aortic wall, posing a risk of distal embolization, causing stroke or limb ischemia. It might be related to an underlying subtle aortic wall injury or a hypercoagulable state. Diagnosis often via tele, CTA, or MRA. Treatment as controversial options include anticoagulation alone, especially if the thrombus seems to be reducing, a surgical thrombectomy, percutaneous aspiration, or endovascular exclusion with a stent graft. The best approach depends on thrombus characteristics, patient factors, and embolic risk, weighing the risks and benefits of each strategy.
Okay, so after diagnosis and treatment, whether medical or interventional, surveillance is absolutely essential across the board. This isn't a treat-and-forget situation for any of these conditions.
Not at all. Regular, often lifelong imaging follow-up is critical. The underlying aortic disease often persists or can progress, and interventions themselves can have late complications. The risk of progression or late issues necessitates ongoing monitoring.
What imaging modalities are used for surveillance?
CTA remains the most common modality due to its detailed anatomical information. However, the cumulative radiation dose and repeated contrast exposure are significant concerns, especially in younger patients who might need decades of follow-up.
So MRI is an alternative.
Yes, MRI is a very good alternative, particularly for longer-term surveillance where radiation avoidance is paramount. The guidelines suggest MRA or CTA for routine surveillance, Class 2A, Level C. For specific issues after TEVAR for traumatic aortic injury in young patients, conventional X-rays might be used to look for stent graft issues like migration, collapse, or fracture, avoiding more radiation.
How often should patients be monitored? Are there standard protocols?
Protocols tend to vary based on the specific condition, the initial severity, the type of treatment received, and findings on previous scans. However, common patterns exist. For example, after an acute type B dissection or for a DTAA managed conservatively, surveillance might be scheduled at 3 months, 6 months, 12 months initially, and then annually or perhaps less frequently if completely stable. Closer follow-up or intervention would be triggered by significant growth, often defined as 5 millimeters per year, or reaching specific diameter thresholds. Routine surveillance imaging is generally recommended, Class 2A, Level C.
And after intervention?
Lifelong imaging follow-up is generally recommended after any endovascular repair, like TEVAR, Class 2A, Level C. This is crucial for detecting endoleaks, device migration, component separation, or late aneurysm development proximal or distal to the graft. After open surgical repair, follow-up imaging, usually CT scan, is recommended around 6 months post-operatively, Class 1, Level C, to establish a baseline and check the repair integrity.
And if problems like endoleaks are found after TEVAR?
Prompt intervention is usually recommended for significant endoleaks, particularly type 1, seal zone leak, or type 3, device integrity failure or component separation, as these maintain pressure in the aneurysm sac and carry a risk of rupture. That's a Class 1, Level C recommendation.
Does surveillance differ for specific conditions, like genetic syndromes?
Yes, surveillance protocols need to be tailored. For genetic syndromes, surveillance often starts earlier in life, may occur more frequently, and importantly, includes screening of first-degree relatives. For coarctation, annual clinical follow-up with echo or other imaging is typical. For inflammatory diseases, surveillance needs to monitor both aortic dimensions and disease activity, though guidelines might be less prescriptive on intervals.
It's clear surveillance is key. But even with these comprehensive guidelines, the source document itself acknowledges there are still areas where really robust, high-level evidence is lacking.
Absolutely. That's an important point of humility in the guidelines. Many of these conditions are relatively rare, making large randomized controlled trials difficult to conduct. Patient populations are heterogeneous. And particularly in the endovascular space, the technology evolves so rapidly that it often outpaces the ability to perform long-term comparative trials.
Can you give examples of specific evidence gaps highlighted?
Sure. The guidelines mention things like needing more data on the true value of specific SCI prevention techniques like mannitol or certain intrathecal methods, the utility of neuromonitoring MSEP during TVAR, optimal brain protection strategies during complex arch procedures that might extend to the DTA, the definitive best management strategy for acute type B dissection beyond the immediate phase, especially regarding preemptive TVAR. Also, the best approach for ruptured aneurysms, optimal treatment for coarctation like bare versus covered stents, why hypertension persists after successful coarctation repair sometimes, and indeed refining those optimal surveillance intervals based on more robust data.
So acknowledging these gaps is important.
Very important. It reinforces that this is a dynamic field. Guidelines synthesize the best available evidence, but they aren't the final word. Identifying these gaps helps direct future research efforts to strengthen the evidence base and ultimately improve patient care.
Okay, let's try to bring this all together. What does this deep dive into the ESVS guidelines boil down to for you, the listener, managing these patients?
Well, I think these guidelines are truly an invaluable resource. They provide a structured, evidence-based framework for managing a really challenging group of conditions affecting the descending thoracic aorta. They cover the whole journey.
Right, from understanding the landscape of diseases, dissections, aneurysms, genetic causes, trauma.
Through utilizing the right diagnostic tools, primarily imaging like CTA, to navigating those complex management decisions. Especially for acute type B dissections, complicated versus uncomplicated, medical versus TVAR versus open repair.
And for chronic dissections and aneurysms, focusing on thresholds for intervention and the pros and cons of different repair strategies.
Exactly. Plus, the critical importance of strategies to prevent spinal cord ischemia, addressing those specific conditions like the genetic syndromes or aortitis, and maybe most importantly, emphasizing the absolute necessity of diligent, lifelong surveillance after diagnosis or treatment.
And it's crucial to remember these are guidelines to assist your decision-making. They don't replace your clinical judgment for the individual patient sitting in front of you.
Precisely. Each patient is unique. Their anatomy, their comorbidities, their preferences. Your expertise lies in applying this synthesized evidence to their specific circumstances. That's paramount.
It's clearly a field characterized by serious, often acute conditions, rapid technological advancements, particularly in endovascular therapies, and a lot of ongoing research trying to fill those evidence gaps.
It really is constantly evolving.
So, here's something perhaps to keep thinking about. Given this complexity, the individualized nature of these aortic diseases, and the rapid evolution we've discussed, how will future advances, maybe deeper insights from genetics or perhaps sophisticated imaging biomarkers, allow us to move even closer towards truly personalized management? Could we one day predict individual patient risk much more accurately and tailor interventions even more precisely than today's guidelines allow?
That's certainly the hope, isn't it? Moving towards ever more personalized aortic care. It's an exciting prospect.
Well, thank you for joining us on this deep dive into the ESVS guidelines for descending thoracic aorta diseases. We certainly hope this has been a valuable use of your time.
Thank you for listening to The Deep Dive.